Family presence during CPR, which will be herein referred to as family presence or FPDR for the sake of time, has become an increasingly prevalent topic in the present-day patient and family-centered care hospital environment. Today we're going to discuss some of the current research associated with family presence and feature commentary from a local healthcare provider who will give us her perspective from a personal and institutional standpoint. In this presentation, we will be providing you with information on family presence while keeping three core objectives in mind. First, we will introduce the current working definition of family presence and examine its origin. Next, we will discuss some of the advantages and disadvantages of FPDR from different perspectives. And finally, we will investigate recommendations for developing written policy within the hospital setting. Recently, researchers defined FPDR as the attendance of family members in a location that affords visual or physical contact with the patient during resuscitation. Now, the concept of FPDR was first introduced at Foot Hospital in Michigan in the early 1980s as part of a program that responded to several families' demands to be present during resuscitation. Initially, family presence research was confined to the pediatric setting. However, after the American Heart Association released an official recommendation in support of FPDR in the year 2000, the concept has gained popularity in adult inpatient facilities. Prior to 2004, FPDR was limited to Western countries and continues to be practiced predominantly in the United States and Europe, although studies are now exploring its applicability in other nations and cultures. FPDR has garnered much attention over the past few decades, which can be directly linked to the trend in increasing patient and family-centered care and decreasing strict visitation hours that were once commonplace in critical care settings. The research is certainly in favor of the benefits of FPDR. In fact, the Emergency Nursing Association and the American Association of Critical Care Nurses have both released official position statements and practice acts declaring support for the practice based on quality of evidence. Among its many advantages, research has demonstrated that family presence during resuscitation can serve to reduce a family's anxiety as well as facilitate coping with the passing of a loved one. And because only 13% of patients who undergo CPR survive, it is important that families are allowed the opportunity for closure in the event that death does occur. If resuscitation efforts are unsuccessful, the patient's family is able to begin the grieving process immediately, which may help them circumvent a sense of denial that is common with the untimely passing of a loved one.
The benefits of a family member being present during CPR resuscitation of a patient are that they could truly see what it means to keep their family member alive. Another benefit is because they are seeing what we have to do to keep their family member alive, they may be quicker to say stop that or to continue.
Family presence also provides families with a better understanding of the patient's condition and reassures them that every effort is being made to save their loved one's life. In 2008, an interview conducted at a pediatric intensive care unit in Loma Linda, California, revealed that the majority of parents who had experienced the loss of a child supported presence during CPR. Of the 21 parents interviewed who were present during resuscitation, 67% believed that touching their child brought comfort to the child as well as helped them cope with their loss. On the other hand, of the 20 parents who were not present during their child's resuscitation, half of them believed that being there would have helped them accept the loss more easily. Resuscitation efforts can be very gruesome and often require invasive procedures and uncomfortable circumstances for all parties involved. Having family members present may help to mitigate this inherently dehumanizing experience. Although there are many advantages to FPDR, it is not without its drawbacks. One common concern expressed among healthcare providers is that the CPR experience can be very traumatic for family members to witness, as many interventions can seem brutal and painful for their loved one. Additionally, family members may not understand the actions taken by staff or the rationale behind them, and the process can appear very chaotic and even inhumane to a layperson. Despite its portrayal in the media, the events that occur during resuscitation are not glamorous. Patients often soil themselves and are covered in blood and other bodily fluids during the process. There is some concern that these disturbing images may replace the last memories the family has of their loved one. We've already discussed some of the benefits of FPDR for the patients and families involved, but healthcare providers also see the advantages in this practice. Because the process of resuscitation can often be very difficult to explain, the presence of the family members creates an opportunity for better communication throughout the process by enhancing the family's understanding of what's going on. This helps generate a sense of trust, allowing for better collaboration between the family and healthcare team. In this way, the provider's ability to make important decisions can include the wishes of the patient and the family. According to some studies, a positive perspective on FPDR differs from discipline to discipline. It appears that generally, nurses are more supportive of FPDR than physicians. A number of nurses feel that family presence allows them to better fulfill the needs of family members by providing comfort, offering knowledge and support, and assisting in the end-of-life decision-making process. Physicians are still divided as to whether family presence is appropriate. In the same vein, there appears to be a positive correlation between FPDR and the enhancement of the nurse-family relationship. One study found that the nurse's attitude towards FPDR improved after being exposed to the connection between the patient and the patient's family. Also, FPDR increases trust between the nurse and the family by decreasing doubt, fear, and anxiety about the patient's condition. Another observation by healthcare staff, according to one study, is a perceived improvement in patient care from their colleagues during resuscitation. Providers noted that coworkers tended to modify their conversations to limit dark humor and increase sensitivity in the presence of the family. It was also believed that their presence reminded providers to maintain patient dignity, manage pain, and ensure privacy more so than in resuscitation efforts performed without family present. When it comes to staff viewpoints on FPDR, some studies illustrate that there are far more perceived problems than advantages. Providers commonly cite family interference with the resuscitation process, increased performance anxiety, fear of litigation, and risk for psychological trauma as their chief concerns in opposition to family presence. Many providers are afraid that the presence of the family will bring more scrutiny to the resuscitation efforts, and they may appear inexperienced. Additionally, some providers complain that there is often not enough physical space in the room to accommodate family members, and squeezing in too many people can both compromise patient outcomes and the confidentiality of other patients in the close proximity of the ER or ICU. As one nurse shares, the family presence can also exacerbate an already emotionally stressful situation, bearing the risk of distracting providers from their task of saving a life.
Family members are not medical personnel. Their anxiety, their emotions can sometimes get in the way of us doing our job during a resuscitation. And so that could definitely be a drawback.
Although the ENA and AACN both endorse formal written policies and procedures for FPDR, only 5% of critical care units in the U.S. had formal written policies as of 2003. Michigan's Foot Hospital remains the gold standard for written policy allowing FPDR in the U.S. In the landmark study conducted there in the early 80s, 3 out of 4 family members said that their presence helped them deal with a family member's death, and 2 out of 3 felt their presence actually helped the dying person. The consequences of not having an established policy can have stressful implications for healthcare providers. When an institution lacks formal policy on family presence during CPR, the nurse or other healthcare providers can be confronted with the ethical dilemma of respecting the family's wishes and the patient's autonomy or honoring the staff's directive. One study involving a survey of trauma nurses revealed that while the group widely supported the practice, 74% of them thought that a written policy needed to be in place at their institution. Several factors need to be considered in the development of policy. Some studies suggest that employing a family facilitator who is specially trained in both social work and nursing will help alleviate the resuscitation team of the task of explaining the process and comforting the family while trying to save their loved one's life. Stakeholders and policymakers should also take into account the need for staff buy-in and education when it comes to family presence. Additionally, cultural beliefs of patients and families could potentially complicate a generalized policy and may require modifications to accommodate for varying beliefs. Hospitals who support patient family-centered care but hesitate to endorse family presence during CPR may be viewed as being inconsistent with their policy and will need to consider how the two concepts are intertwined. In the future of policy development, the nurse will play an increasingly important role in facilitating family presence during resuscitation. Nurses are often in the best position to speak to a patient's condition because generally they have spent the most time with them as compared to the other members of the interdisciplinary care team. Their familiarity with both the patient's unique condition and their existing relationship with the family make the nurse an ideal candidate to facilitate family presence. Given these factors, we may eventually see a paradigm shift in the nurse's role during resuscitation from being at the patient's bedside to the family's shoulder. Thank you for your time and attention throughout this presentation. Please direct any questions to our team through the VISTA tool.